So this is her AP view of her right elbow taken um, in the office. This is with her splint on. So this is her lateral view. Splint's been on for 2 weeks. And again, at the outside institution, she was verified as having been reduced. So let's start here. Rob, any thoughts? This is a 2-week-old injury at least coming into the office, still dislocated.
Yeah, these are always tough, and your heart sinks when you see these X-rays and these patients in clinic. There is no easy fix for this, right? Like this is a grossly unstable injury. There's a piece of bone sitting in the joint. It's probably from the radial head, maybe it's from the coronoid. We'll figure out, with more imaging and things later on. Um, Even if I think one of the important things is even if there is no piece of bone sitting here, this is going to the OR and not just for a closed reduction because you could say, oh, well, the splint is not quite bent enough and it wasn't padded enough. And maybe if I take her, I can reduce her and I can get this in and stay. You cannot. An elbow that's been out for 2 weeks needs surgery, even if all the bones are perfect. And we know the bones aren't perfect because I see that chiclet sitting there. So I am laying a bunch of crepe. I'm going to tell this person this is a long road. Really, it sounds like she's neurovascular intact, which is fantastic, but we got to talk about that after whatever we do, ulnar neuropathy is not uncommon. Be very aggressive about releasing any nerves that may be weak. I always check AIN function in these patients because from the swelling, they can get a Lacertus or a pronator syndrome. And if I'm operating on the elbow anyway, it's a shame to miss that and have to come back and do that later on. But in her comorbidity, she's diabetic, she's overweight, so she's like a metabolic kind of nightmare. So it tells you your soft tissue healing potential is already a little compromised. So I'm laying a bunch of crepe right from the door.